This evening, I show you my experience in this new field, and the only problem is the time, because this field is very full of information, and today is not possible to analyze everything in deep. But we start with short presentation. Sorry. Okay. So the graph material are divided in 4 types of graph material. We have autogenous bone, autograft human bone, xenograft, and alloplast. The property of autogenous bone is osteoconduction, osteoinduction, osteoproliferation, and the xenograft and the alloplast have only osteoconduction. So what are the most used graph materials? The most used are xenographic and alloplast. They are the 87% of the market, and the only property is the osteoconduction. What is the osteoconduction? The osteoconduction is the ability to produce a scaffold where it's possible for the cell to starting from the peripheral areas to the defector in order to generate new bone. And this material are hydroxyapatite, natural or synthetic. So the osteoconduction is the ability to sustain the new bone graft and the bone growth. And for example, in this image, it's possible to see, this image is from Geisler website. It's possible after 9 years to see the granules from xenograft material completely surrounded by bone. But there are inside the regeneration. So the problem with this hydroxyapatite is the crystals are too large. It's impossible to be remodeled or reabsorbed from the bone. What happened after 20 years? This is my image from my X-ray. This is a socket preservation made 20 years ago, and in the X-ray it's possible to find something strange, because this socket preservation have a white spot where you can find the granules after 20 years. In this image, courtesy of Dr. Libertucci from Rome, the Dr. Libertucci made a regeneration 8 years ago, and the last year have the possibility to make a biopsy in this zone. And when we open after 8 years a flap, it's possible to observe some granules, white granules on the surface of the new bone, on the bone. And what is this material? This material is is the presence of the graft material in the middle of the bone. And this material is like a stones inside the bone. So why we use this material? We use this material because we try to copy the nature. So the alveolar bone is made from 65% of HA and 35% collagen and proteins. So the 87% of the market is made from a copy of the nature, and we try to copy using HA. So we test the presence of using a xenograft material, and in our test, in this image, we have a histology of this test. It's possible to observe the granules in pink, and in red, the new bone. So after 6 months, we found the 24% of new bone. The other part of this histology, there are like stones. Obviously, if you place an implant in this bone, we have a contact bone implant very thin, not like 100% of the surface. Why we decided to analyze the tooth as graft? Oh, we decided because we know the tooth have two properties: the osteoconduction and the osteoinduction. What is the osteoinduction? The osteoinduction is the ability of material to be able to stimulate the cells to produce new bone. And why happened this osteoinduction? Because inside the alveolar bone, for example, because the bone is able to have osteoinduction, we have 65% of HA plus 35% collagen and proteins. And this part, the proteins are able to stimulate the new bone. So what changes if you have same situation, for example, socket preservation after 6 months? On the right side, on the left side, we have the image we have seen before, and this is the same situation after 6 months, and we use only a dentin. In this case, we have new bone, 56% of new bone after 6 months. If you use a xenograft material, we have only the 24. So obviously, if you place an implant in this site, we have a contact with bone implant very thin, and in this case, we have a 55% of bone able to have a contact with an implant inserted in this site. So the difference between a tooth and bone is very thin. For example, enamel is completely different from alveolar bone because the 96% of HA with high density and the crystals of the HA is a prism, the big dimension, with a big dimension. But the dentin have the same quantity of inorganic parts and the dentin is made in HA with a low density, and the alveolar bone have the same quantity of HA, but the dimension of the HA is flat and nano dimension. Is like 10 times lighter than the dentin. And the organic part is the same. We have the 35% collagen and proteins. But if we analyze this part, we have the 35% is organic, 90% of this 35% is collagen, and 10% is not collagenous protein. This non-collagenous protein is very similar between dentin and bone, and in this image it's possible to observe what proteins are. So the proteins in common with bone, what we do, they create everything we want for a GBR. So, for example, stimulate the angiogenesis, stimulate the production of mineralized tissue, stimulates the osteoblast differentiation, and increase the numbers of stem cells. So, this is possible to conserve the tooth for a long time. In this analysis, we analyze, not we, but Smith and Schultz analyzed the presence of growth factor in Neolithic age tooth and middle age tooth and present tooth for 3 different growth factors: insulin, EGF2, BMP2, and TGF-beta. And the surprise is the data, because after 1,000 years, it's possible to find the same quantity of the proteins inside the tooth. Why is possible this result? This result is possible because we can image the dentin like this wall. Every brick, white brick, is HA, and the colored brick are the proteins. So the HA is the hardest tissue in nature, and is able to protect the protein. So we have two effects. The first one is the protection during the time, and the second one is if you want to free these proteins, it's necessary to reabsorb the surface of the granules, and when the dentin will be reabsorbed, the proteins will be free. So we analyzed a lot of articles in literature, and it's interesting to observe the difference between the analysis of the clinical cases made in literature from 1967 and 2050 and 2020. The articles in humans are doubled, and that indicate the possibility to use the tooth with new devices like Tooth Transformer and the other devices on the market. So how we got the TT? In this image, it's possible to observe the difference between the dentin, the bone, very similar in this image, and the xenograft material. Xenograft material is completely different to the bone and to the dentin. So we start to try to find something, a device able to use the tooth. For this reason, we found we start the test in University of Milan, in Polytechnic of Milan, and we divided the test in two levels. The first one is to find the procedure, and the second step is the test with the procedure. So we analyzed the demineralization, the morphological evaluation, the content, atomic content, the DS analysis, etc. And in the second way, we analyzed the evaluation of the viability of the cells and the production of the osteocalcin and the presence of proteins after the treatment. So, for example, obviously, we spend like 1 year in these studies, but today we have a very short time, and it's impossible to explain every test we made, but it's possible to observe in this image. If we use a different procedure, we have different results on the surface of the granules. So we analyzed, for example, HEL, we analyzed ADTA, alcohol, ethylic alcohol, and I don't remember all the tests. The surface obviously is completely different. This is the tooth, not untreated tooth, and you can observe the difference between each different procedure. So the other different selection criteria was the wettability, the ability to create granules able to have a high wettability to have the possibility to use in surgery with very high and with handling, interesting handling, and another aspect is the biocompatibility, the cell adhesion, and the bacteria-free. So we analyzed every aspect, and for example, in the biocompatibility, it's possible to observe. The native dentin, untreated dentin. The surface. This is white, black spot are the cells on the surface, and we have a certain number of the cells. But with the treated dentin, we have a very high number of the cells on the surface. The same thing with the enamel. The enamel untreated is without any cells on the surface, and after the treatment is very similar to the xenograph with a shape and with the numbers of cells on the surface. Another aspect we analyzed in that studies is the presence of the the proteins after the treatment, and we analyzed, for example, the presence of the collagen, the presence of BMP2, and so after these steps, we produce a device able to transform the tooth in this way. So the first step to use the tooth is the cleaning the tooth. We use in this movie is possible to understand. We use a high-speed bar, diamond bar, and we clean the surface. And after we cut the tooth, okay. So we clean to, we need to eliminate the filling, the cement on the prosthesis, or the other material not from the tooth. Okay, and now we cut. We use a disc, and we cut because inside the device is possible to use a low-speed grinder, but the low-speed grinder have a little space inside, so we need to cut the roots. And another reason why we cut the roots is that to be able to clean the endodontical material. So we cut, and after we use a clamp to stabilize the tooth, and to clean inside with a bar. In this way. We made 100 tests, histological tests, and in no one we found something not from the tooth origin, for example, guttapercha or cement. And I suggest to clean with big attention, and sometimes I use a Google to understand if it's completely free from this material. The second step is dry, and is to dry the tooth, because it's very important to have the tooth very clean and dry, because if it's wet, the device is not to work. And okay, this is the device. We have a grinder. The grinder, we place inside the grinder the tooth, and we insert the little pieces of the tooth inside. We close the grinder, we insert the grinder, and after we insert the single-use unit with the liquids and the maker, so we pierce on the surface to activate the liquids, and after that we close the lid and we push the button to start the procedure. At the end of the procedure, it's possible, after 20-25 minutes, it's possible to find this material. Okay. Because the procedure is 30 minutes long, I suggest to do one thing. Normally, I do this procedure in my clinic in this way, because obviously is impossible. For example, in my clinic is normal, but I think it's impossible to lose 30 minutes to wait the material. So, for example, I made an extraction at 9, and I place another patient during the time to the procedure, and after 30 minutes, I start the GBR with TT. So I save time and I save money. Two of the most common mistakes are to place inside the tooth with prosthesis or wet teeth. Okay, so at this point we start with the clinical test. We made a test with the sheeps, and we place a cage inside the mandible of the sheeps, and we insert in some cage a dentin treated and untreated dentin in the other cage. And this is the control. This is untreated dentin, and after 2 months, it's possible to observe we have a granules without dentin, without new bone surrounding the dentin. Only in this part is possible to observe a little quantity of bone, also here. But if you observe the same situation, the same sheep, and the same time, with the dentin, treated dentin, it's possible to observe a big quantity of bone surrounding the granules. So after that, in February 2016, we start with the first patient. This patient, we have an image for this patient because she's a vegan woman, and we have a prototype. This is the prototype of TTT, and she wants to use absolutely the tooth, and she don't want to use a xenograft material, because I use normally in the last 20 years xenograft material, but she don't want to use something from animals. And so we use the dentin of this root. We have a fracture of the 36 of the root of the 36. So we made a GBR, alveolar socket preservation, and this is the result after 4 months. We place an implant, and we made a biopsy after 4 months, and this is the healing after the healing of the implant, and this is the comparison after 4 months. It's possible to note the presence of some granules on the surface, and this is the result after 4 months. This is not important, this is not a result, interesting clinical result, but is a very interesting follow-up. So after 56 months, the result is very stable. The tissues is like a natural bone. This is another alveolar ridge preservation. We have an implant failure. We lose a lot of material around this implant, and this implant is very near to the alveolar nerve and the alveolar canal. And so this is the image with tissue surrounding the implant, soft tissue surrounding the implant. We remove the soft tissue, we remove the implant, and we have a communication with the alveolar canal. And so we place a collagen membrane on the dip. We insert the material from the tooth, extracted in the other side, and we place a collagen membrane on the top. We place a stitch, and we start in this situation, and this is after 6 months. So I would like to focus your attention here, because here there was a very big hole, and after 6 months it's impossible to understand where was the hole. And this is the X-ray result after 6 months. This is the result of the histology after 6 months, and the new bone was 63%, and the tooth transformer was 0.1. So all the granules, all these granules was completely resorbed and create a real absolutely new bone. Okay, this is another case, very interesting, because it's alveolar ridge preservation using decidus tooth. The decidus tooth of this patient, she's a young woman, 26 years old, and it's impossible to use these teeth because these teeth have a prosthesis, and also they have a big endodontical treatment. So we decided to use the wisdom tooth, but the patient don't want, and the mother, after 2 days, come back in my clinic and tell us we have in a plastic container, this plastic container, they have a decidus teeth from this young woman. So we choose some one of these teeth, and we cut and we use it to make the regeneration. This is the regeneration, the surgery. This is after 3 months, and this is the X-ray analysis after 3 months, after 6 months, and this is the sagittal transaxial image after 3 months and 5 months. It's possible to observe. It's possible to observe the density of the bone after 5 months. So we open a flap, we place 2 implants, and this is the result. Histological result. Is very interesting to understand. This is a dentin completely surrounded by new bone. This is the new bone. This is osteocyte, and in yellow is the enamel. It's interesting to understand the enamel is completely surrounded by new bone, and it's possible this result because the enamel after the treatment is very, very similar to xenograft material. So if you use the enamel, is like a dentin, is a bone with mineralization, and the enamel is like a xenograft. So in other image, it's possible to observe a piece of dentin with an enamel, with the crack, the fracture of the treatment, and completely surrounded by new bone. We have a lot of osteocyte in this site, and also this part of enamel completely surrounded by new bone. And this is the result at the end of the treatment after 24 months of follow-up. This is another alveolar ridge preservation. This is the situation before, and this is a situation after, I don't remember, 30 months, probably. This is a big defect. We lose like 10 millimeters in vertical dimension, and probably 20 millimeters in horizontal dimension. And it's possible to observe, to compare this image with this image after 2 months, because we remove the tooth, and we have on the maxilla we have a white spot, so it's possible to compare exactly the same section of the CBCT, and this is after only 2 months. After 2 months, it's possible to observe a high quantity of new bone, and after 6 months, we have a implant inserted inside, and this is what happened. This is after 2 months. We open a flap. It's possible to observe material with a lot of granules, and this material was very dense, and it's possible to insert the 2 implants without any problems, without a stability, and with a stability. And after 4 months, it's possible to observe the presence of a cortical new bone everywhere. So where here there are granules, after 4 months, we have a cortical new bone. So 48 months of follow-up. This is the result, clinical result. And this is another case, very interesting, because in this case, we remove this tooth, we have a big defect for the distal root, and we remove this tooth, we use the inflammatory tissue to cover the defect, and we place inside the granules, we use a membrane to cover, and to cover on the top, we place an inflammatory tissue, and this is the result after 4 months. And when we open the flap, this is the tissue. It's possible to observe the difference between before and after. This is the only all new tissue, and we can insert a big implant, 5 millimeters of diameter, and we have a new prosthesis. And this is a sinus lift to understand what happened in the sinus. So we place material, and when we open the flap, we insert the prosthesis, and the result is the material will be transformed in a bone. It's impossible to find the difference between the bone and the material inserted inside the sinus. So this is our book. We have an Italian version, and probably in March we'll be able to produce the English version. And I show you some cases from the clinical cases from this book, because from this point I show only my cases, and is not only in my hand this analysis. And we have a lot of friends. They made a very interesting cases using TT, and okay. This is another case from a Spain friend, and this is an Italian friend. This is a Singapore friend, and this is another Italian friend. So every case is very interesting, and is not only in my hand. So we have a question. They tell me if it's possible to mix the xenograph material with a dentin. Yes, it's possible to mix, and because sometimes when we remove at root, it's not possible to produce a lot of material, because sometimes with a prosthesis the roots are very thin, and probably the defect is very big. So we inserted the dentin like a boost in the regeneration, and we mix with a xenograph material, for example. But what do you see in histologies after 4 months? This histology was made from 11 different clinics, and this is a case very interesting, because is exactly on the topic, because they tell me if it's possible to mix dentin and xenograph material. This image is a histology after 4 months. In this alveolar socket preservation, we insert 50% of xenograph material in pink, and in red the 50% of the dentin. So what happened after 4 months? After 4 months, we have a new bone 24%, dentin was 3%, and bios 38. Very interesting is the image after 4 months, because it's possible to observe the dentin was, I remember, 50% dentin and 50% bios. The dentin was also resorbed. So the granules inside create a new space for a new bone. The other granules, the xenograph material, are not resorbed, so they don't create a space for a new bone, but only the new bone is able to surround these granules. But if you use dentin only, what happened after 6 months, 4 months or 6 months? Because our analysis is made after 4 months or after 6 months. In this case, we have 2 different histologies, and the total bone was 46%, and new bone 40% on the left side, 42% on the right side, and the 2 transformer, so the dentin was only 6% and 4%. So it's a big difference, because in that case, we have only the 24% of new bone. In that case, we have 46%. So in a lot of images, we can observe this situation. This is a granule of dentin. This is a new bone. On C, we have the osteocyte, and in D, we have the core of calcification. So we have a lot of this image. What means? It means the ability of the dentin to be osteoconductive material, and when the dentin will be osteoinductive, will be when happens this thing. This thing is when the osteocyte, the osteoclast eat the dentin and free the proteins. So we have this image, is very, very interesting image, because we have the granule with the A and surrounded completely from new bone, and here there is an osteocyte eating the dentin. The same thing is in this image, it's very clear. This is a multinucleated osteoclast, and able to resorb the surface of the granule. This is another image of the granules completely surrounded by new bone, and in this image is interesting because we have a dentin, a granule of dentin in transition. What's mean the transition? Because this granule was this. So only here is the residual dentin, and in the other part was completely absorbed and substituted by a new bone. And in D we have osteocyte, and this is a transition substitution, and this is the tubules of dentin. So we made 129 histologies, and we divided these histologies in 4 different levels. Why we divided in 4 levels? Because we would like to understand if, obviously, every surgeon, every surgery is completely different. So when we made a biopsy, depending the result, depending to the hand from the dentist, from the surgeon, and depending also from the typology of the surgery, and so we have a lot of different. But if we have a lot of histology like this, it's possible to observe where is the normality. So at the level 3, we have the 41% of the cases, and what means level 3? Every level is connected to the quantity of the new bone. So we have the 60%, the level 1 was with minus the 30%, and the 29 level is minus 40%, and the 41 is minus 50%, and the 40% is a measure of the 50%. So we can observe some example. This is the level 1, where the bone is minus 30%. In this case, the total bone is 31, but the new bone is only 50%. and the tooth transformer is 50%. So we can observe a lot of space between the granules and some soft tissue between some granules. This is not a good result, but we don't know if the possibility is from the dentin or from the surgery. So the level 2 is bone in is the total new bone is 35%, for example. The dentin is partially resorbed, and we have a good quality of new bone. And the new bone is, in this case, in this image, is 29%, and the tooth transformer is only 5%. Level 3, this is the most common result in our hand, and you remember this case is 40% of the totally cases of the analysis of the histological analysis made. And in this case, we have a new bone 40% and only the 6% of the dentin. So we can observe some granules like this, like this, like this, but most of the granules are completely resorbed. And this is level 4. This is a goal when we made this surgery. Is a complete surprise when we found this type of bone, because this type of bone is like a cortical bone, and the total bone in this example is like 80%. It's very, very rare, but only the 14% of the cases have this result, but we have. So what happened in X-ray evolution? This is an example, 48 months. This is 2060, 2017, in March, in May, we place implants, September, December. So what happened? It's very interesting because it is possible to observe the granules after some month, 4 months probably, and after 1 year disappear completely. And in this case, we have is impossible to understand where was the defect, and is impossible to understand where was the new bone. This is very interesting analysis, is present inside the book, because we analyzed the different result, histomorphometical result between different typology of the surgical procedure. For example, we use a normal collagen membrane in the first case, and second case, and third case. We use only a collagen membrane to cover the graft material, and we use a Begos, collagen Zimmer, Extend, OsseGuard, and the result is very interesting because the bone volume was 45%, 44 with this collagen membrane, and 51 with this membrane. Obviously, in that case, we have 32 histologies, so probably we have an incidence of bad result to the total volume. But it's interesting to observe if you use a CGF, PRGF membrane only, the result is completely different, but not too much different. So I think the dentin have a high influence of the result in GBR. So this is the steps in literature. First step was in vitro result. So we publish some articles about our study in Polytechnic of Milan. And for example, we analyzed the dimension and the load of the tooth to be able to understand if you remove, for example, a molar, what is the quantity of material produced after the extraction, and when we place a molar inside the device, how much is the material. So 1 molar is normally like 2 grams. So if you place inside the device, we have 2 grams of material. And it's very big quantity. And sometimes, if you remove a molar, for example, a wisdom tooth, and we need to make a socket preservation, or I don't know, periodontal problems, we need only a little part of this tooth. So it's possible to cut this tooth, to use only one part, and to store the other part for another situation in the same patient. So the second step was in vivo result. We made some cases, and the third step was a multi-center study where we analyzed different situations. For example, the root canal therapy. It's possible to use the tooth with root canal therapy. Yes, it's possible. We have the same result. And we compare, for example, in this study, the use of the whole tooth and the endodontical tooth, and the endodontical teeth, and the result is very similar. So it's not, we don't have any different to use the endodontical treated teeth and the whole teeth. So we analyzed also the sinus lift, and the step 4 was the comparison with other material, where we place inside the same socket the teeth and the teeth with xenograph I showed you before. And this is the result. Is very interesting because we have a big difference between the mixed with xenograph and alone. But it is possible, and we have a good result also mixed. Also, if we mix the dentin with xenograph material. And the step 5 was the decidus teeth. So we try to use the decidus teeth because in literature we have a lot of analysis of the presence of the BMP2 in decidus teeth, and it's interesting to understand the quantity of the BMP2 is very high in the decidus teeth. So a source of graft material is free. From the only question is to maintain during the time, and it's possible to place. I show you before in a plastic container and have a good result after 20 years. So all graft material are similar to the human bone, but they are not original human bone. Why we use the tooth? Because the tooth is original autologous mineralized bone. The only difference between bone and dentin is the quantity of the mineralization. So why we would like to use the dentin? Because we have a better quality of the new bone in a short time. And another very interesting aspect is the interest of the patient about this technique, because every patient would like to use their own part to make a regeneration. So, for example, if I would like to buy a Ferrari, it's possible to buy a similar Ferrari or the original Ferrari. So I think use the tooth is like use the bone, and the bone from the same patient, from the patient, autologous material, with all the ability of the autologous material. So I finished my presentation. I think is interesting for you. Send me if you have a question. I'm very sorry for the short time, but it's possible to analyze in deep in probably in 4 hours, but it's not possible in a webinar.
You have the question, Professor Minetti.
Yes, I see. It is a problem that a patient wait for 30 minutes with an open wound. No, it's not a problem. Normally, we made all these cases in this way, and we don't have any type of problem. We place only one stitch, and we wait 30 minutes. And is not a problem. Obviously, we open a flap. This is only for the extraction. So I extracted the tooth. I don't open the flap. I wait 30 minutes, made something different, like another patient, and after that, I made a surgery. So I opened the flap after 30 minutes, and that's it. Everything is good, and the result is every day optimal.
Okay, thank you so much, Professor. Thank you so much, Doctor. I will send you for email tomorrow for the contact and all information about it. Thank you so much for all. Have a nice evening. Good night.
Thank you to all. Thank you to all. And if you have a question, send a question to Diego or send me an email here. It's not a problem. I try to answer to all. Bye bye.
See you soon. Bye. Thanks.
Bye bye.